the projected number of cancer diagnoses in the United States for 2024 was more than 2 million. And the number of cancer survivors by 2032 is estimated to be approximately 22.5 million. The estimated national expenditure for cancer care in 2020 in the U.S. was $208.9 billion, more than the GDP of over 150 countries worldwide. This is not the healthcare expenditure. This is just the cancer care expenditure for 2020. Needless to say, cancer management has become a societal issue with its multifaceted and diverse set of challenges. Oncologists are not mere physicians, but a pivotal part of our society, as they are the ones who face and handle these issues on a daily basis. Unfortunately, we have not done enough to maintain or revive the well-being of our oncologists or our profession. A survey conducted by the prestigious American Society of Clinical Oncology reported a significant deterioration in professional satisfaction of the oncologists, with over 59% respondents reporting one or more symptoms of burnout, compared to 34% in 2013. Approximately 1,750 community clinics and/or practices have closed or shut down, been acquired by hospitals, merged, or reported financial struggles since 2008. Empowering Oncologists is a podcast brought to you by OncoDaily, where we will focus on day-to-day concerns of an oncologist's work and being, with a vision to find sustainable solutions. We hope to share our stories of wins, losses, resilience, and inspire and empower our community, because we fly higher and longer when we fly together. Before we dive in, a disclaimer. Views shared on this podcast are an individual's views and in no way are the views by any organization, institution, or guidelines. Welcome. My name is Jasmine Kamboj, and I'm a community oncologist and hematologist practicing in the states of Minnesota and Wisconsin. For our session today, we have Dr. Jon Ticku, who is board-certified community medical oncologist and hematologist practicing in La Crosse, Wisconsin, with the Mayo Clinic Health System for over 12 years. He's an assistant professor of oncology at the Mayo Clinic and leads the GU Medical Oncology for the Mayo Clinic Health System. He has served on numerous committees over the years, and over the past 3 years has developed and dramatically expanded the telehealth oncology and hematology practice in the region. Jon is an avid reader and now an avid audiobook listener. He has skied over 1.5 million vertical feet in the last 10 years. We will dive into that later on the show. Jon, welcome and thanks for being here.
Thanks, Jasmine. Thank you for doing this and shining a light on the community oncology practice. We're often seen to be overlooked nationally, but I think this spotlight will be us.
Awesome. Jon, you've practiced as a community oncologist for over a decade. What prompted you to go into community oncology?
A lot of during training, I liked both oncology and hematology equally well. Hematology was quite fascinating, and I didn't want to give that up. Many of the academic or large practices, you either focus in oncology or hematology, and practice in the community appealed to me as well. So it really was a perfect fit for me.
That's awesome. I was like that too. I like both hematology and all solid tumors. So I was like, I got to be a community oncologist. So you've been in this practice for over a decade. What has been some of your tools that you use for your sustainability or your resilience?
I do a number of different things over the years. Everybody has noticed the administrative aspect of the practices have encroached onto time spent like with family or reading. I've definitely noticed the administrative issues like the EMR, et cetera, have encroached into the time I spent reading literature. So I use different ways of kind of keeping up, like listening to things on my phone or reading articles on the phone on the go, different modalities. I also use like a note-taking app to keep kind of things in my mind. If I hear something at a meeting and I want to jot that down, I use like a operating system agnostic one called Evernote. So it's real snappy. I find it's very effective. I know some of my colleagues use OneNote,
Uh-huh.
but that's just one little technique that I've used over time as well. So that's something kind of, leveraging the technology to try and stay up to date and being flexible as possible. I think that that's one of the things I do. From the standpoint of kind of keep staying resilient, I kind of try and exercise, making that a priority. I think that that's important. I'm not perfect at it, but I try and keep that in mind. So those are kind of the main things that I do.
Yeah. So staying on top of the game by using and utilizing different tools to keep yourself updated, and also at the same time trying to like not let yourself burn out are your key tools essentially.
Yeah, I tend to take vacations, like very regular vacations, like once every 3 months. I'll try and make sure I take time off. Some people don't do it like that. They'll take a big vacation like once or twice a year. For me, I think like taking periodic time off regularly helps me out, recharges the batteries.
That is a great advice for our incoming fellows, because I feel like in training we tend to clump our vacation once or twice a year, but in real practice, because it's not going to end in 3 years,
Yeah.
you have to stay on top of your vacation game as well.
I think we were on the still resiliency after that. I was also going to make mention that, for the fellows coming out into community oncology practice, that having strong hematology background, I think, is essential. Like it's not going to be just disease specific. Maybe the breast cancer doctor would be the most disease specific in a community oncology practice, but really, the majority of people have to practice 1, 2, 3 sites, and then
Right.
also fold in hematology. And on the weekends and on call, when you're on your own, it's helpful to know a lot of hematology. So that's kind of a very good thing to focus on as well throughout.
Right. That's a great advice, because as fellows, I think we all tend to shy away from hematology and lean towards solid tumors. But in
Mhm.
real practice, hematology has more emergencies like acute lupus
Mhm.
and TTPs. That's correct.
Yeah. Yeah.
So Jon, tell me about, the current evolving landscape. Share with us some of the tools with which you keep yourself updated. The FDA approved 50 novel therapies last year, out of which 15 were cancer therapeutics. And if we were to include all the new indications for cancer management, there were over 50 new indications.
Mhm.
So how do you keep up with all of this?
Yeah, it's definitely an excellent question. And the thing that I put it as, like, I try and lump things together a lot more. So I focus a little bit more on class of drugs. So the classes of drugs I find don't change as frequently as the indications or the new drug and number. So I just try and learn the class, and kind of add little nuances to what I've learned. So CDK4/6. There's a number of drugs in that category now. You sort of learn one, and then you just add little pieces on, and it makes it a lot easier to kind of consume that knowledge and remember things. The latest is the bispecific antibody therapies. So I started trying to go back and learn that from myeloma, and then now that we're getting that like creeping into solid tumor now, I think these are things that we're just kind of building on. Maybe the CRS is not as much in like tarlatamab as it was, and maybe some of the others or myeloma. So, but the kind of the overall scheme is the same, so to speak. So it's
Right.
not as daunting. I feel like I'm able to use that little technique to stay on top of things, I use like OncoDaily or through the email to kind of keep up on what's happening with the FDA as well as far as approvals go. And I
Right.
also lean on my colleagues and meetings and things like that. So journals, etc. So it's all the sources. Everybody has a little bit different method, but
Right.
those are the type of things that works for me.
That's awesome. Those are some very great insights. Yeah, for me, I think Ask a Post is always open on my clinic desktop and my home desktop. I think my son knows more about Ask a Post now as well. Okay. So let's shift gears and move into the rural oncology aspect of our clinics, right? So we are all community and rural oncologists, and we all have small suburban area clinics and definitely cater to a lot of rural population, which, by the way, per 2020 census, we have around 57 million people residing in rural America, which is around 17% of our total population. But only 10% of oncologists practice in rural America. So needless to say, there's obviously, a healthcare gap and disparities. How do you tackle this? What is your approach to that?
Yeah, excellent question. I think that this is going to be like, if we don't address this, it's going to get worse over time. So what we did in our system, particularly, leveraging telehealth to fill that gap.
Mm-hmm.
So going back a little bit historically, post pandemic, a lot of places, ourselves included, had difficulty with recruitment. We were short staffed. And we have a hub and spoke model within Western Wisconsin. We have two hospitals, one in Eau Claire and one in La Crosse, about 70 miles apart, with surrounding smaller clinics, mostly primary care clinics in the surrounding areas. So we did have some outreach to one of the clinics that I actually went to was in Tomah, Wisconsin, which was about an hour east. I would go there 2 afternoons a month. It became, with being short staffed, it became harder and harder to take time away from the main clinic to drive there, going back and forth. So what we did was decide to leverage our telehealth practice. And our first pilot back in 2022 was with the telehealth, use a teledoc machine within the primary care clinic at that site. And that was well received. We analyzed the patients that we treated there, the patients that we saw in that clinic through the telehealth services, and it really helped to bridge a gap between technology. So not high-speed internet wasn't available in a lot of areas, particularly in that Tomah area. And the way the older patients were utilizing the technology wasn't as robust as what a younger patient would. So it really helped them. We analyzed the patients that we saw there. They skewed older, 75 or older mostly. And those were the patients that would typically have to have their family member bring them down, take the day off of work to bring them to the clinic. And it increased efficiency for the patient, it increased efficiency for physicians as well. We never restricted the timing for just an afternoon or every 2 weeks. We have them being able to schedule any time, morning, afternoon, Monday through Friday, onto the oncology calendar. So it was really well received. And based on that, we expanded it to 5 others of those clinic sites.
That is awesome. And tell me, did the elderly population, did they have any issues with technology, or did that come very easy to them?
So they did have some issues with technology. A lot of it was actually broadband penetration to the rural areas, which is a longstanding problem, and to this day. The technology that we use was in the clinic, where we have what we call a teledoc machine, which is a freestanding, connected machine that has a stethoscope, and with the MA can listen to, and nursing, listen to the heart, lungs as well through that machine. So that bridged the gap of them having to actually figure out the technology, and having the broadband capacity to be able to do it. So it really put the oncology virtually in that site wherever it was, whatever time it would be, without having the inefficiency of running back and forth, both for the oncologist and for the patient.
So the patients are going to their nearby clinics, and you are doing hub and spoke from your mother hub and doing teledoc from your clinic. That's
Correct.
wonderful.
Yep. Yeah.
That is awesome. And that's actually a really good point, because if we want to expand telehealth and telemedicine to rural America, we need to have support from broadband and internet services as well.
Yeah. And the total proof of concept of this whole thing, which was unexpected, was last year, a year ago, basically now, where our sister hospital in Eau Claire, 2 hospitals closed unexpectedly in that area, and they both had hematology and oncology services at those hospitals, and those patients all needed to come find another place for treatment and care. And so they basically went to our sister hospital in Eau Claire, overwhelming their capacity, basically. So we were able to utilize our existing oncology resources, oncologists, APPs, and utilize the telehealth services to relieve a lot of the backlog that was happening with that huge influx of patients. So it was a total proof of concept of what could be done utilizing our oncology workforce efficiently. It was an amazing thing. Actually, the oncologists in that region were still able to take their vacations on schedule too. So it was really rewarding to be able to help out like that to our colleagues, for sure.
That is a spectacular success story. So when the surrounding hospitals shut down, instead of overwhelming the current hospital system, you expand your outreach and take advantage of your sister hospitals using telemedicine. And if I'm not wrong, I think they had a backlog of 100 plus consoles, and you guys took care of that very successfully. I think that's great.
Yeah, it's a really great proof of concept, and there weren't new doctors that were hired. We just kind of used our existing staff how we needed to. It was just really kind of amazing proof of concept. We never planned it like that to be like that. It was, but we had the existing infrastructure in place and the existing workflows, etc. So we just expanded to what we had. So amazing.
And that's another good point. Like, when we don't have to wait until emergency falls on us, right? We have to continue to hone our systems in a way that when emergency does happen, we are prepared to take care of that, right?
Yeah.
Jon, in your practice, have you used telemedicine or any of the modalities in your clinics to, bring clinical trials or just to reduce disparity gaps for rural populations? How does that work?
Yeah, that's a very good question as well. We haven't, this is one of the concepts that we are always thinking about. And I think it lies within a little bit more within like federal regulations as well, and how you can conduct a clinical trial and what kind of virtual capacity you can have for enrollment. But these are things that are in discussion that I know, and it would be a fantastic thing. Based on particularly, let's say, our rural region. We've established this infrastructure of having the ability to kind of reach in virtually into the rural communities. If someone comes along with the plan through regulations or are relieved, et cetera, to be able to overlay their clinical trial onto the current infrastructure we've already laid out, that will definitely be able to bridge gaps.
Wonderful. If you have to pick top 3 changes in your current practice or in the oncology landscape, what would those 3 changes be for the well-being of your fellow colleagues and for a more seamless workflow in your clinics?
Yeah, I think that a good one for me, I've always dreamt of this, and it seems like well within reason, is why can't the EMR predict what I'm going to do? So I'm ordering, for all of us, we order, for an oncology patient, we end up ordering kind of certain labs or certain scans pretty pretty period, at a reasonable kind of clip. So why can't it just predict what
Mm-hmm.
we're going to do ahead of time? So within our system, we use Epic, and it can be cumbersome putting in a CT scan and then typing in what the indication is for a lung cancer,
Mm-hmm.
and filling in all these other little things. I mean, it's just the same patient.
Mm-hmm.
We're just repeating that. Why can't it just fill that out for us? I think that's kind of like low hanging fruit there.
Mm-hmm.
Uh, some inbox management. I think it's a little bit, we're trying to get better at it, but getting a little bit of help. I don't know the answer to that. It seems like pretty chaotic what's happening in baskets
Mm-hmm.
for the most part to me. There's a lot of somewhat redundancies there as well.
Mm-hmm.
I haven't obviously fully tamed the in-basket problem, so I don't have a lot of solutions there.
Mm-hmm.
But hopefully somebody else listening to this may come up with a solution. But those are some of the main things right now.
Right. Right. I think one of the things for the in baskets, I think, I really appreciate the nursing support and the navigator support when we get it. It's really
Yeah.
helpful.
Yeah. Yeah. I think is something that I would love to have a little bit more of about structured, but
Mhm.
um, let's see what happens there.
Right, right. So with all of these challenges, the disparities and EMR issues, administrative burdens, etc., if you have to relive your life, John, would you still choose oncology?
Yeah. Yeah. 1,000%, I would do it. I think for me, it was highly interesting field. I have a high intellectual curiosity for what we do. I love taking care of patients. I love interacting with my colleagues. I find that oncology and hematology in the field is so fast. It's inherently lending itself to collaboration and discussion, and we have to gather each other's opinions. And it's just like we tend not to work in a silo as far as decision making oftentimes, and it's very collaborative. It's really a great field. I think we're also practicing in an amazing time. When I think about what's the historically about oncology, last 15 years, it's we're practicing in that unbelievable time right now. All
Mhm.
the changes, all the new medications, all the new treatments, treatment modalities like theranostics, bispecific
Mhm.
antibodies. All of these things are coming online now. It just really, I have a lot of enthusiasm for what we do, and
Yeah,
I think it's just the future is bright for our field.
for sure. I strongly believe in this. I think oncology is moving faster than AI is.
Yeah, yeah, true. That's a good way of thinking about it. Awesome.
Yeah, yeah. All right, John. Let's dive into a little bit of a rapid fire. So, what are your favorite books?
I like I said, I read a fair amount, so I like a number of books. I would say that just kind of some of them I like that are inform how I work in my clinic group as well. And just some are just general books. There one I really like. I recommend AI Superpowers. This is a book by Kai-Fu Lee. He published it in 2021.
Mhm.
That was around the time where, there was a little bit of buzz about artificial intelligence and trying to know kind of what that was. It gives a little bit of history behind like where we were and why there's such a buzz about artificial intelligence.
Mhm.
Uh, and, and after reading that book, it gave me a lot of insight into even to this day. Over the past like month or so, there's a large language model called DeepSeek that made a big splash. And it sounded like in media, there was a lot of surprise, but I read that book a number of years ago and I had zero surprise that happened. It was no surprise to me. So it gives you a lot of insight
Mhm.
about what is happening there's a lot of books out there probably that do the same thing, but
Yeah.
that's a very good one. I really liked it. Um, there's another book I like by Ray Dalio called Principles. He's a principal. Ray Dalio is the founder of a company called Bridgewater Capital Management, and In that book, he gives like that company has been so successful. The management style has been studied. So there's a lot of like tips that I took about how to run a group or just my clinic group. I have a team, our APPs, nurses, pharmacists, other MDs that are on our team. How you arrive at a decision, how you collectively arrive at a decision rather than one person running with it forever. You collectively come to a decision faster if you get everybody's opinion, no matter what level they are in the care team, basically. So that's how we operate a lot. I like the book David versus Goliath. It just it highlights, it has an application to community oncology a lot in the sense that you don't have to be big to be great. Greatness can come out of the small team as well. So small teams are very innovative. So like our illustration of what we've done with the telehealth practice, and we innovated in a small way, and it's almost like created our own like startup company within our health system, and within our service line, we've expanded that telehealth dramatically. So there are some really good books that I like. I had one more in mind, but it'll come to me in a little bit.
Wonderful. Those are excellent suggestions, and I think I'll have to check them out for myself so I can use some tips from them for my practice too. Jon, who's your favorite leader and why?
I would say Ray Gallo. Probably after I read the book, I've never personally met him, obviously. But after reading about that management style, it's more of a flat management style where any criticism is taken very seriously. They talk about in the book how the most junior person criticized him pretty severely, and they take it to heart without retribution. So it was like, nobody's too high up in the chain for criticism, and it's not taken the wrong way at all. So I think that's a great style, particularly I think for growth of any organization.
That is very profound. Feedback, especially negative feedback, is very important. What's your favorite cancer study?
It was like kind of this phase 1 paper that came out in New England Journal of Medicine back in 2012. It was more of the proof of concept PDL1 paper about immunotherapy. That it wasn't so much the actual results of the paper. It was more that, that's kind of generic study of proof of concept of PDL1 was published in the New England Journal of Medicine as a phase 1. It just kind of struck me as something big is on the horizon. So that's one of the studies that I always kind of fall back on and think that, wow, that's a pretty big thing.
So you kind of read between the lines and you saw what was coming. That is awesome.
Yeah, exactly.
What's your favorite sport?
Cycling to watch. I participate in cycling, and I like watching it, or bike racing. It's more of a European sport. It's like endurance. It's an endurance sport and a chess match all in one. So there's a lot of once you get the nuances of it, there's a lot of tactical things that are going on within a bike race. It's a very beautiful thing to watch.
Wonderful. And if there's one advice you have to give to Jon Ticku of 10 years ago, what would that be?
I'd like to say that, in the 10 years post-fellowship is important to work quite hard. Because I saw a lecture a long time ago, even before I finished training, about the trajectory of people after they finish training, and the learning doesn't stop there, even though you're pretty fatigued by all the training programs.
Right.
If you kind of stop there, you can become a little bit more stagnant and sideways, but there can be a lot of learning and a lot of clinical expertise gained in the decade afterwards. And I think that's important to keep in mind.
Very good advice. My last and a fun question. You've skied over 1 million vertical feet. How do you measure that?
Oh, yeah, that's with the new apps that are on the phones now too. So just depending on which resort you're at, it'll track it for you because there's like these there are these scanners at the lift line, so it scans you and figures out where you're going and how many feet you're going. So it's good technology. I don't know if it's perfect, but that 1.5 million, it sounds a lot more than it actually kind of is. It's I think a lot of people could do that, but it just sounds kind of puts it into perspective. It's a long ways.
When I learned this fact about you, I'm like, am I talking to somebody who holds a Guinness Book of World Record?
Far from that. There's a lot of people, but I thought that was like a little fun fact because I did go on vacation not long ago, and that stuck in my mind.
For sure. And one more thing, tell us a little bit about Evernote. You said you use an app called Evernote.
Yeah.
What is that about, and how do you use it?
Oh, yeah. So it's just an app on the phone. It's like a note-taking app, basically. It's very snappy. I just create a note on the fly of things that I want to remember. If if you take if you're at a meeting and you take a picture of a slide or something, and if I do that, I incorporated that into Evernote and make a little kind of note for myself to search back on it as well. So it's like a little repository for all the things I want to remember. And so, there's a lot of different ways. I know there's a native app for iPhone, and then there's probably something for Android. But I think for me, I found that something that is like agnostic to whatever computer I'm using. I can go to my iPad, and if I have my iPad out, I can search for whatever I need. And all of those things I kind of put as a little repository for that. So yeah, it works well for me. I think everybody probably has something like that. There are organizational techniques as well. So that works.
Thank you. So what would be your, three key takeaways or three guiding points from our today's chat? Lots to discuss.
I think we have to, in the future, we're going to have to leverage this technology. I think telehealth is going to be extremely important in oncology and hematology. For our previous example, utilizing the existing technology actually helped us. With the same footprint of a clinic, we were able to kind of almost like have a oncology and hematology virtual program running alongside and outside of the physical clinic, creating efficiency within that existing infrastructure that was already there. I think that's going to be very important. If we think about like creating efficiencies within our oncology workforce, whether it's in a urban setting or a rural setting, I think it's not going to matter. I think all the trainees that I see in the fellowship programs, I mean, they're these brilliant people, and their peers probably are in tech companies and all these things, and it's probably appealing to them to see practices that are leveraging this technology very well. It'll probably be an advantage for recruitment down the line as well. So I think that those are the telehealth that we talked about today will kind of be beneficial in that regard too.
Wonderful. Well, thank you, Jon, for these spectacular insights around our episode today, which is joys and challenges of community oncologists. And the three key takeaways for me, I think the discussion around rural and community oncology is refreshing and much overdue. So I'm glad that we're getting started with that. And it's crucial to close the disparity gap. Telemedicine is a key tool, as you mentioned, to leverage both for rural and community oncology settings. And organizations and leadership need to continue to work on creating efficient tools like telemedicine and supporting their systems and physicians with maybe sometimes even small steps like getting us gym memberships or ski passes.
Yeah.
Yep. So thank you. And thank you for our listeners. Thank you to our listeners. And this is Jasmine Kamboj signing off from the podcast brought to you by OncoDaily called Empowering Oncologists. Thank you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. hit the bell icon to stay updated.